Okay, thank you. Welcome, everyone. Good morning. I'm Michael Farrell. I'm the Policy Development Manager for the Washington Medical Commission. And this morning is our interested parties meeting. This is part of a new process to foster engagement with the public and with the licensees and with the profession on commission documents, policies, interpretive statements, et cetera, prior to the commission's policy committee meeting. The policy committee meeting will take place on October 13th. So what we want to do today is show you a couple draft documents that are going to be discussed at the policy committee meeting on October 13th and give you the opportunity to provide feedback to us, commission staff. There may be some commission members on as well. I see Dr. Domino is on. She's the chair of the commission. And we will take notes and have a interactive discussion to get your feedback on these documents, two interpretive statements. So with that, I'm going to begin with the first one, which is on your screen, which is called Qualified Physician Under Optometry Law. And a brief background is that the legislature passed a law last spring that expanded the scope of practice for optometrists that they could do advanced procedures. The document lists the advanced procedures that optometrists can now perform. And then the law says that an optometrist can perform these procedures once they get a license endorsement from the Board of Optometry. The law provides that the Board of Optometry will issue the license endorsement when the optometrist successfully completes postgraduate courses designated by the board, successfully completes a national examination for advanced procedures, and enters into an agreement with a qualified physician, either an MD or DO, for rapid response if complications occur during an advanced procedure. The draft provides that the law does not define what a qualified physician is. So the commission is using this document to attempt to define what a qualified physician is. And at the bottom of the document, it lists the proposed 4 qualifications for an MD to qualify to be a qualified physician for an optometrist to perform advanced procedures. And so the proposal is that a qualified physician is, number 1, someone who holds a license as an MD with the Washington Medical Commission, who is currently not under an order or a STID, stipulation informal disposition. In other words, it's not under current disciplinary action. Number 3, that they hold a current and unrestricted certification from the American Board of Ophthalmology. And 4, they have a surgical suite on site or they hold privileges at a local hospital. So I welcome any feedback on this draft. Anybody wants to chime in? Yeah, Stephanie?
So just to introduce myself, my name's Stephanie Kramer. I'm an ophthalmologist that practices in Longview, Washington, and I'm currently the president of the Washington Academy of Eye Physicians and Surgeons. So as many of you know, we were very active in opposing this bill in general over the last legislative session, but I really want to thank you for this interpretive statement with regards to this agreement with what constitutes a qualified physician. In particular, I'm very happy we are as an organization happy with the stipulations number 3 and 4. Number 3, recognizing that it needs to be a board certified ophthalmologist, not necessarily any physician, but one that can manage a surgical complication of an advanced surgical eye procedure. And then with regards to number 4, you're recognizing how dire these complications can be that occur during these procedures, specifically ruptured globes, which is when a sharp object penetrates the eye, requiring urgent surgical repair. Also uncontrolled bleeding, that could lead to irreversible blindness from a retrobulbar hemorrhage, again requiring urgent surgical repair. So I would urge you to hold fast to all 4 of these facets of your statement with what regards a qualified physician. The other thing that we'd like to comment on, and I think we submitted some written comments to a couple of days ago to the Washington Medical Commission, is just with regards to the agreements. If we go back up to the language there, these agreements pertain to physicians that would be responding in a rapid way for complications that occur during a procedure. Now, the way the bill is stated, it doesn't have any, I guess the first thing to note is that it doesn't identify what a complication is. So there's, your members and us as ophthalmologists really don't know what we're signing up for here. So we would urge you to maybe weigh in on even the definition of a complication. And then the other thing is it doesn't really recognize that almost all complications to any surgery in any field, some unfortunately do happen immediately, but most happen subsequent to the procedure, either in the hours after, days after, infection being one of the primary ones. And so we would appreciate maybe having that be part of the interpretive statement as well. So not just complications that occur during the procedure, but also subsequent to the procedure. The other point that we'd also like just to note is that in Section 4 of the bill, there is a reporting requirement, and that reporting requirement is with regards to adverse events. So adverse events, again, in this bill are not defined. And so if we're going to be the ophthalmologists and the qualified physicians managing these complications, we would also like to at least weigh in on what these adverse events are that we're going to be handling respectfully. And so those are just the comments. Again, I think we supplied them to you in written form, but we're really thankful for your help in this process. We want to make this as safe as possible for patients, and kind of defining the complications, perhaps adverse events that we're going to be helping manage would be very helpful for us to make it as safe as possible.
Okay, thank you. Hillary Norris, you have your hand up.
Oh, hi. Yes, Hillary Norris representing the Washington State Medical Association. I just wanted to say thank you for the opportunity to provide comment on the interpretive statement regarding qualified physicians under SSB 5389. The WISMA is supportive of the WMC's interpretation that only a board-certified ophthalmologist with access to a surgical suite or hospital admitting privileges should serve as a qualified physician and enter into agreements with optometrists performing advanced procedures. This provision is critical to patient safety, as only an ophthalmologist has the expertise and training to respond to adverse events in, on, and around the eyes. And the WISMA does share WAPES's hope for additional clarity around adverse events and complications, and agrees that the WMC is the appropriate regulatory authority to weigh in on those matters. So, thank you.
Thank you. Any other comments? If not, we will go on to the second document. I want to make sure no one else has any comments on this interpretive statement. If you later have comments, you can submit them, and we will bring those comments, of course, to the commission at the policy meeting. Okay, Amelia, let's move on to nitrous oxide.
So unfortunately, I am not able to share documents for some reason in this webinar. I've tried changing all the settings and it will not allow me to do it. So and Jimmy's not available to add it to the website. So,
Okay, that makes it challenging for people to follow along.
I can probably share it on the screen.
That'd be great.
Okay, hold
I
on, let
can't
me get
put it
that
in the
set up.
chat.
Okay, can you see the document now?
Yes, I can. And for the people in the audience, this is a little bit of a complicated one, and I'm sorry that we just finished the draft this morning. We wanted to bring it to this meeting. I wonder if there's a way I can get it to all of you now. I'll tell you what, we will post it to the website. The person who does that is not in today, but we'll post it first thing Monday morning. And you can submit comments after that. But let me go over it quickly. This issue has to do with physicians using nitrous oxide in their offices. And the issue is this. So a number of years ago, the commission adopted a rule governing office-based surgery. And the rule essentially says that if a physician uses less than general anesthesia and performs and more than minimal sedation, then they have to comply with the rules of the office-based surgery rule. And the rule has a number of requirements, but the central requirement is that the physician has to ensure that the facility in which they're performing the procedure is accredited by an approved accrediting entity, such as triple AHC or Quad A SF or the Joint Commission. There has been an issue that was raised that the use of nitrous oxide is really minimal sedation. And if it's minimal sedation, it should be exempt from the rule. But the language of the rule suggests that nitrous oxide is really not minimal sedation, although it's not specifically addressed. So what this interpretive statement attempts to do is to explain that the use of nitrous oxide is exempt from the commission's rule, provided that the physician meet a number of requirements. And this is a lengthy document listing all those requirements. We looked at the dental anesthesia rule, which says that the use of nitrous oxide in a dental office by a dentist is minimal sedation. However, a dentist has to comply with a number of requirements. The requirements are quite similar to the commission's requirements in its office-based surgery rule. So what we did in this draft was we added the requirements from the commission's office-based surgery rule into this draft, with the exception of the requirement that the facility be accredited, since that was the main issue here. So I'm sorry if that's a little bit confusing, but the bottom line is this document provides that a physician using nitrous oxide alone does not have to have their facility accredited in order to comply with the rule. That's the bottom line. So if you look at the beginning, this is the heart of it. You could scroll up the first paragraph. It says that the commission interprets its rule. You can scroll up just a little more, Amelia. Can't see the first sentence. The first sentence is the key. There you go. A physician using nitrous oxide is exempt from the requirements of the rule if they administer it at a concentration of 50% or less. It is used without another inhaled anesthetic, a sedative, or an opioid drug, and the facility in which the procedure takes place has certain safeguards listed below, and we'll get to them. So if a physician using nitrous oxide uses a concentration of greater than 50%, and they use another inhaled anesthetic or sedative or an opioid drug, or the facility doesn't meet the certain requirements, then the physician is not exempt from the office-based surgery rule and the facility has to be accredited. So Amelia, if you could scroll down just a little bit, and I'll just go over the requirements for the facility. Keep going. A little more. Okay, here we are. So these are the requirements, and these requirements come from the Commission's office-based surgery rule. Number one, the physician has to be competent and qualified to perform the procedure and oversee the administration of nitrous oxide. They should take CME in the administration of nitrous oxide analgesia. Scroll down a little more. They have to have at least one licensed healthcare practitioner currently certified in advanced resuscitative techniques appropriate to the patient age group. That person must be present and immediately available. Sedation assessment and management. If there's not an anesthesiologist or CRNA present, then the physician intending to provide a given level of sedation should be able to rescue a patient who enters a deeper level of sedation than intended. The physician must return the patient to a lighter level of sedation as quickly as possible while closely monitoring the patient to ensure that the airway is patent, the patient is breathing, and that oxygenation, heart rate, and blood pressure are within acceptable values. Scroll down a little more. There has to be a separation of functions. The physician performing the procedure cannot be the person administering the nitrous oxide or monitoring the patient. There has to be emergency transfer protocols, and they have to keep a good medical record. Again, all of these requirements are in the Commission's current office-based surgery rule. Scroll down a little more, Amelia. Okay, one addition, if you go up a little bit, one addition that was added to the documentation requirement. Scroll up just a little bit more. Okay, F, documentation of vital signs. This is not in the office-based surgery rule. It probably should have been, but the physician is required to document vital signs during the nitrous oxide sedation, including respiratory rate, oxygen saturation, heart rate, and blood pressure. Okay, scroll down to scavenging. This is also not in the current Commission office-based surgery rule, but we added scavenging of nitrous oxide to protect staff. The physician should use scavenging to remove excess nitrous oxide from the operating room. So that's a summary of the proposed interpretive statement. Dr. Domino helped me draft this, and I wonder, Dr. Domino, if you want to add anything to what I've said.
Sure. We were just trying to allow this to be used in offices in a reasonable concentration for patients, and provide some safeguards. So we thought, and then they don't have to do their certification. So I think it accomplishes patient safety. The documentation of the vital signs, I think is important to ensure that someone's actually watching the patient, which could be a nurse. So that's what we put.
We welcome comments now. Ms. Norris?
Sorry.
Muted.
Thank you. Sorry. So yeah, Hillary Norris again, representing the WSMA. So I just wanted to say thank you for sharing this language. And we will get commission feedback ahead of the October meeting and share any feedback we receive at that time. Thank you.
Great, thank you. Sorry for the late sharing, but we appreciate your feedback. Dr. Bundy?
Good morning. I'm Chris Bundy, Executive Medical Director of the Washington Physicians Health Program. I'm just curious if any thought was given to including any language in here about safeguarding access to nitrous, after hours, controlled access to the delivery mechanism. We see use and misuse of nitrous oxide amongst dental providers and dental professionals can be a significant risk for basically occupational exposure and misuse. I don't know if that was considered or if it's even appropriate here, but I thought I'd raise it as a question.
It seems like a good idea. We didn't really think of that. We just figured that adequate training would prevent and for proper storage and use, as well as patients' contraindications to certain medical conditions that patients have. But I think explicit language sounds good because it is a big issue.
Chris, are you aware of any dental regulation covering this?
Are you asking me?
Yes, I'm asking you. You mentioned concern with dentists. Are you aware of any dental regulation on this?
No, but I think efforts could be combined. I think it'd be interesting to we have worked with individual dentists and dental practices around safeguarding access. Oftentimes we find that there isn't adequate safeguards, but giving only certain individuals access to the room where it's centrally controlled. It could be shut off during non-operating hours so that it restricts flow of gas to the chair. Those kinds of we sort of invent those things to safeguard dental professionals where that has been an issue. But I'm not aware of any specific guidance or recommendations with the Dental Commission. That doesn't mean that there isn't any. It's just not in my awareness. Be an interesting question to ask them and to maybe collaborate with them on.
Thank you. I don't see any other hands raised. Amelia, am I missing somebody?
Doesn't look like it. Uh-oh. Again,
Many of you are seeing this for the first time. I apologize for the late sharing. We will put this on our website Monday morning. We welcome feedback. The policy committee meeting is on October 13th. The policy committee will be discussing these two documents. The commission business meeting is scheduled for October 20th. So that would really be the deadline for submitting feedback on either of these two documents. We can take them via the website. You can email me. I will put my email address in the chat.
And Mike, I was able to email the document to everyone who registered to attend today.
Great, thank you. Any other comments, feedback? If not, we'll wrap it up. Please understand that this is a new process. We've instituted having an interested parties meeting. We hope that this is helpful. We'll be having one approximately 2 to 3 weeks before every policy committee meeting. We encourage you to come back and engage with us. And of course, you can call me or email me at any time with feedback. We welcome your feedback. We welcome public input. We think it makes our documents better, our policy better. And that will be it.
It's Chris Blake. Thank you, Mike, for handling this for me. Sorry I had to jump in late, but it looks like we had a pretty good audience, so I'm happy to see that.
Thank you, Chris. Okay. Thank you, everyone. Have a good weekend.
You too.